Schizophrenia Spectrum Disorders, Chapter 12. So a lot of our objectives today is to understand at least 3 of the neurological, biological findings that indicate schizophrenia as a brain disorder, and to differentiate the positive and negative symptoms of schizophrenia and the treatment and the effects of the quality of life. These are several of the terms that you need to become very familiar with and have understanding of and application and interventions for. So, schizophrenia affects only 1% of the adult population, and it's characterized by psychosis, which is basically an alteration of the following areas: cognition, perception, and reality testing. 75% develop gradually, presenting at typically between ages 15 to 25 years of age. It can onset in childhood and possibly even late onset and late adulthood, but those two are more rare occurrences. Typically, again, onset is in adolescence to young adulthood, and typically we see it more around the ages of 18 to 25 years of age. So to be diagnosed with a schizophrenia, we are looking for somebody to have significant portion of time, at least of 1 month, having delusions, hallucinations, disorganized speech, gross disorganization or catatonia, negative symptoms, which are part of an inclusion of diminished emotional expression or evolution. When we've talked about what evolution is, again, that lack of motivation, goal-oriented, okay, and functional impairment of some kind. So they need to have 2 or more of those sections, of those symptoms, and a continuous disturbance for at least 6 months. So Eric M. is an 18-year-old who has always been a good student. However, in his 2nd semester of college, he begins, for the first time in his life, to have trouble concentrating. When his family doesn't hear from Eric, they contact the school only to discover that his roommate says Eric is talking weird. Asked what they mean, his roommate says, well, you know, he says stuff that doesn't connect, doesn't make any sense. I asked him if he was high or something, but he says, no, I don't believe him. On further investigation, Eric's professor says he's been missing class after starting out so well. Eric's roommate says his speech doesn't connect. It doesn't make sense. He sort of gets derailed. Which of the following symptoms is Eric displaying? Evolution, delusional speech, disorganized speech, diminished emotional expression. This should be C, disorganized speech. That's characterized by that derailment or incoherence. It is not necessarily always a negative symptom. It's characterized by diminished emotional expression or evolution, nor is it characterized by delusion. Now, we could have alogia, a lack of speech, but that's not his case. Right now, it's disconnected, and it's not making sense. Epidemiology. We know that childhood onset in schizophrenia is 1 out of 40,000 children. We also know that there is no difference related to race, social status, or culture when it comes to the diagnosis of schizophrenia. We do know that the frequently diagnosis we see among males more often, and that in urban areas we see the diagnosis. But for epidemiology-wise, race, social status, and culture plays no impact on this. Now, we do see for comorbidity diagnoses, substance abuse plays a factor. The biggest one is nicotine dependency. Patients with schizophrenia have a higher correlation of having a nicotine dependence. And it is a strong correlation there. We also see anxiety, depression, and suicide as comorbid conditions with patients with schizophrenia. You will also see a diagnosis called schizoaffective disorder, where a patient has a mood disorder with schizophrenia. We'll talk more about that in just a little bit. We also see patients being diagnosed with health issues and illnesses. Well, why would that be? Let's see. We have our patients being prescribed antipsychotic medications that cause weight gain to the point that morbid obesity can occur. So if we could pile on morbid obesity issues, let's see, if you get morbid obesity, we have cardiac issues that occur, hypertension issues. Then on top of that, if you have second generation, you're at increased risk factors for metabolic disorders. So we're talking diabetes, hyperlipidemia, high cholesterol, high triglyceride levels. So there again, cardiac issues, blood pressure issues, blood glucose levels, circulation issues, peripheral artery diseases. Then we have our movement disorders that can occur. Okay, so now we've talked about just that with the medications. Now let's talk about the disease itself that actually causes avolition, that lack of motivation to take care of yourself. So are we going to do follow-up appointments? Are we motivated to exercise and eat properly? Are we even brushing our teeth and taking care of ourselves? Then I have polydipsia on here. This is, of course, on page 193 that it talks about this, but we talked about this with our bipolar patients. Do you remember that polydipsia, that compulsive drinking of excess fluids? It happens in 20% of those patients diagnosed with schizophrenia. We talked about the polydipsia, especially with the patients that take lithium. But this group, this has nothing to do with the lithium. It has to do with the dry mouth. And what happens when we're drinking that excessive fluids? That's right, that hyponatremia that occurs, and that water intoxication. So your patient ends up becoming confused, having delirium, hallucinations. They have worsening of their psychotic symptoms, and then they eventually end up in a coma. So what happens? That dry mouth combines with compulsive behaviors and their neuroendocrine abnormalities, and they have that sudden onset of symptoms that occurs. So they may be stabilized, but all of a sudden everything just worsens suddenly because we're having that fluctuation in their electrolytes. Their vital signs are going to fluctuate. We need to know we've got to get those labs right away. We've got to move, electrolyte imbalance. We've got to recognize our patients in medical crisis. So now we have the etiology. We know genetics plays into this. We know we typically see that it skips every other generation. We know, of course, dopamine is a big part of what plays into this, but we also know that serotonin, glutamate, and GABA also play in as part of the neurotransmitters. We also know, looking at page 195, all the other pathways that play into the brain for abnormal structures. So when we're looking at all of these elements, we know that neurobiological also, that amphetamines and cocaine can induce psychosis. Marijuana can increase the risk of schizophrenia in anybody that is biologically vulnerable. It can alter the genetic component in that little weak brain, and that patient is at risk of having problems. So we have to be very careful when that patient uses, because it takes one time. And if a patient is using any kind of substance, whether it be cocaine, marijuana, and they start to hallucinate, they start to having abnormal behaviors, if they cannot come out of it within 2 weeks, that change is permanent. They're not going to come out. And a lot of times between sometimes especially college students, when they go off to school, it may be the first time they use, on top of the additional stress of going away to school, being responsible for themselves, taking on all of these changes that have happened with school, whether it's eustress or distress, it's stress. And it can be just enough that somebody who is vulnerable, it can push and trigger their first psychotic break of their schizophrenia. PCP can also induce a state that resembles schizophrenia, as well as NMDA receptors. Okay, so just trying to give you guys a little bit of an idea of some of the things that can occur. But take a look at all of the different dopamine pathways, just to be a little bit more familiar, of just giving you an idea of how the hypothalamus plays in, how the different tubulars play in, the mesolimbic pathways. Just so you're a little bit more familiar. It's not anything that I'm going to say memorize, but just be aware of how much everything plays a part of the structure of your brain and how it works, and how those stressors and structures play in to your factors of life. So we also know on page 196 that psychological environmental factors, of course, play in. So prenatal stressors. Do you know that fathers that are 35 years and older at the time a child is conceived, their sperm, meaning the sperm of a male that is 35 and older, or if a child is born in winter or early spring, or if a mother has an infection during pregnancy, increases a risk for a child to have schizophrenia. Psychological factors I had talked about earlier, like going away to college, sexual abuse, chronic poverty, increases one's risk of potential schizophrenia. These are just some of those things that can cause or potentially place a person at risk. These are in and on page 196 of just being able to list some of these things that can help you to recognize some of these factors. Do you know that dry cleaning solvents, the toxins that are in them, used to just be put into the environment and get back into drinking water, and that those have also contributed to, along with cancer, also contributed to schizophrenia. So these are just some of the things that we know. So Eric's parents arrive on campus and he agrees to meet with them and the campus counselor. He appears anxious. He's depressed. He expresses sorrow that his grades are suffering and acknowledging that his concentration just isn't there. He says that he feels something weird is happening to me and describes frequent distressing thoughts. He admits to feeling suspicious of everyone he passes. Eric's parents and counselors both notice what his roommates had described about Eric's speech. Applying the nursing process. So, how do we deal with common reactions the nurse may experience while working with someone with schizophrenia? And we're going to work on teaching plans for patients on first-generation and second-generation drugs. Okay, on top of that, we're going to work on evidence-based interventions for psychosis, hallucinations, cognitive disorders, and then, of course, role-playing interventions. So, some of the things you need to know, and this goes back to page 192, but also on page 196, you also have this. So, predominal. What this just means is this is the onset of some mild changes that start to happen in a person. And a lot of times everyone doesn't recognize that there's a problem going on. They just think some things are kind of a little bit odd. There's this little thinking's a little different, moods a little off. But there's subtle little changes typical, and people don't really recognize that there's a problem. There's not enough information to say this is schizophrenia, okay? Because it takes months or even up to a year to really recognize or see the full-blown illness, okay? So once in a while, I'll even see where a patient might get diagnosed. Maybe they have ADHD. Maybe they have bipolar disorder. Maybe they're just a little eccentric, okay? Or they're just odd. But they start to deteriorate in like their ability to concentrate, at school or their job or their social functioning, okay? Maybe they have a little bit of distressing thoughts, or they're suspicious. Their memory's a little bit impaired. They're just not quite right, okay? So that's kind of how it starts. And so there might be a little bit acute. They could be stabilized or in a residual stage at this point in time. So acute would mean that the symptoms are kind of really noticeable, like the young man that we're talking about. Then in the stabilization, the symptoms seem to die down and they seem to be doing better. And they movement towards, previous back to their functioning level. And then maintenance is there's a new baseline that's established. So this is kind of where we're at with how we're looking at our patients and how we're working with them and achieving their goals. Okay. So Eric agrees to see a psychiatrist, and on the initial assessment, the history indicates that he has only been experiencing some mild changes to his thinking and mood for about a month, ever since returning from winter holiday. The examiner confirms the speech is disorganized, and his ability to concentrate and study is diminished from his previous long standing as a strong student. Okay, so we're hearing all of these things here. And on page, let's see, where is it? On page 193, there is the DSM-5 criteria for schizophrenia. Now, some of the things you need to know, and just go back to that first page, is some of the criteria needs to be existing for at least 6 months on some of these episodes for actually having a full diagnosis. It's not just 1 month on some of them. It's for 6 months. Okay, given the evidence we have so far, if Eric has schizophrenia, which is suspected and which phase is he most likely experiencing? Acute, residual, predominal, or stabilization. You should have picked predominal. It's mild changes in his thinking and mood and insufficient to meet the criteria at this point in time. During the predominal phase, general assessment, we're going to look at positive symptoms, negative symptoms, cognitive symptoms, and affective symptoms. Affective is expressive symptoms. In speech. So I'm going to talk about delusions first before we flip over to the other sheet there. So let's start this over again. So positive symptoms. These are the areas we're going to start with. Alterations in reality testing, which is delusions, which is a false or fixed belief. So delusions, remember, is all about a belief, believing something. Okay? So you believe this, you believe that. Alterations in speech and concrete thinking, the inability to think abstractly. So when we're testing somebody on concrete thinking, we're going to be using proverbs for having them work on seeing their understanding of their component. So we're working on their ability to understand their thought processes, okay? So we're going to reality test. Now, when we're reality testing somebody, okay, I want to put in, we are not going to say, with somebody who has a delusion and they think someone's out after them, we're not going to say to them, nobody's after you, because what you're doing then is calling them a liar. And no one's going to trust you. You're going to hurt your relationship with your patient. In your therapeutic relationship, you want to establish a rapport. You want trust that's going to be there. So what you're going to say to that person, how do you say this to them and reality test them? When they're hallucinating, when they're having a delusion. I don't see what you're seeing. Can you tell me more about what you're seeing? It must be difficult to feel like someone is out to get you all the time. So you need to acknowledge how they're feeling, but you don't say that you don't believe them, because that's not our job to rub that in their face. But also when you do that, what they're going to do is hold on to that delusion, hold on to that hallucination and argue with you about it, which makes it even more real to that person. So let's talk about that alteration in speech. We've got some terms that you need to connect with. One of them is word salad. If you want to follow along with me here, it's going to be on top of page 198. So word salad is probably the most extreme form that we see and that we'll see. And this is just going to be a jumbled up mess of words that is going to be absolutely meaningless to you. So when you're talking with your patient, they're going to say cup, soup, yes, no, come, let's go, yes, no, hamburger. Just a whole mess of words. It's like taking your salad and mixing it up. Word salad, literally. Just take the words and mix them up in the bowl. And they're going to not make any sense to you whatsoever. Okay? Clang association. We talked about this with our bipolar patients. We see clang association much more often with our bipolars than we do with our schizophrenia patients, but we can see them. Again, this is going to be that rhythm of sound. It's all based on sound. And it's going to be click, 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 clack, cloud, click, clock, close, but it's going to be especially the hard sounds. Neologism. This is going to be words that are going to have meaning only to the patient. My best example, and it comes from Mary Poppins, is when the word was created, supercalifragilisticexpialidocious. Even though the sound of it is something creditocious, even though it didn't really have a meaning. Okay? It just was created from nowhere. People will just create words that are made up words. Okay? Neologism. Then there is echolalia. Oh, this one's a good one, you guys. This is a biggie. I want you to think of Polly want a cracker. Polly want a cracker. Polly want a cracker. Anything you say, this person is going to repeat back whatever you say. Okay, so say you have a patient and you're asking them for what they would like for their meal choice for their main course, a hamburger or a hot dog, and you even have the hamburger and hot dog in front of you, and you're saying, would you like to have the hamburger or the hot dog? And the patient will literally say back to you, will you like to have a hamburger or a hot dog? And even if you want this patient to pick it, they're not able to do that. So could you imagine having this patient on your unit and all they're doing is repeating back every single word any patient is saying or any person on that unit is saying? So what do you do? How do you manage that person? What can you do for them? If your thought is, I need to decrease their stimuli by removing them from the environment so they don't hear all these words, you're absolutely correct. That is exactly what you want to do. Decrease the stimuli so they don't hear all these words. Because one, they're going to get a hoarse voice because they can't stop themselves. This is started again on page 198. Then we have other speech patterns that you need to be familiar with. Circumstantiality. This is often tedious details in conversations. Again, that patient that is telling you the story about something, they will eventually get to the point, but instead of taking the interstate there to get you to St. Augustine, they're going to take every single side road that's going to go down to 15 miles an hour. And so it's going to take you 2 hours to get to St. Augustine instead of the 15 minutes by interstate. The tangentiality, this is where the person will wander completely off target and forget their point completely. Most of the time the patient will say to you, I forgot what I was talking about. Then there's cognitive retardation. And remember, the term retardation means slowing in the land of nursing. Slowing. Okay, so this is represented by delaying in your thoughts, your speech, those kind of components. Okay, so with this, you're going to generalize slowness in thinking, which represents then a delay in responding to questions or difficulties in thoughts. And so you can also see that, then you'll probably see a logia occurring when this is happening. You need to give that person more time to respond. Of course, this pressured speech, that urgency or intensity to tell you everything, and they can't get it out fast enough. Remember, you may have speaking loudly than usual on top of that urgency to tell you everything. The flight of ideas, where they're moving much more rapidly from thought to thought to the next, making it difficult for you to follow that conversation or others. You may have symbolic speech, where using symbols instead of direct communication, such as the demons are sticking needles in me, which may be a person's experiencing sharp pain. Okay, and that's how they're telling you what's going on is they're using symbols by telling you demons are sticking needles in me to tell you that they're having pain. Then there's things like thought blocking. This is a reduction or a stoppage of thoughts interrupted by hallucinations are usually what's causing that. Thought insertion. Oh, this is a good one. This is when someone believes someone else has inserted a thought into their brain. Once in a blue moon, they think that they can insert thoughts into your head, but most of the time they think somebody's inserting it into their mind. Then there's thought deletion. That is where thoughts have been taken or missing. We have magical thinking, the belief that thoughts or actions affect others and their consequences. Very powerful. Then there's, of course, paranoia, that irrational fear, and it can be from mild to very profound. So where they're weary and guarded to believing that other persons are out to kill you. So during the assessment, Eric has trouble staying on topic, zipping rapidly from one thought to the next, making it hard to follow what he's trying to say. What speech disturbance is he exhibiting? Pressured speech, circumstantial, flight of ideas, or tangential? If you said C, flight of ideas, you're on target. Alteration in perception. Okay, so we have a few different alterations of perceptions. The first one I'm going to talk about is what we call depersonalization. This is where a person feels things are unreal or having lost an identity, that body parts don't belong on their body or they've drastically changed. Okay, so a bad story that I can tell you about, and this has happened, is a patient that I had several years back. He was in the hospital for med-surg hospital for a while because what had happened is that he swore his hand was not his own hand. Okay, his right hand, or actually it was his left hand, wasn't his. He swears he was kidnapped by aliens and they did something to him, and that they transplanted an alien left hand on him. And so he tried to chop it off. Okay, so he was not successful. He did a lot of damage, but they had to surgically do a lot of work on it to keep it engaged and attached. So when he came over to us, he had, and this was what was really difficult, is because he had an exterior, I cannot even think of the name of the equipment that was on it, but it was screws and wires, and it was totally attached together exteriorly to keep it all held together at this point in time when he came over to us. And he still thought it was an alien arm that was attached to him. Even we had to do a lot of working with him. But he depersonalized. It just wasn't real. It wasn't part of his body. And he tried to cut it off. We're going to talk about some other things where you can be depersonalized during trauma events. Okay. So anyway, this isn't just one example of a depersonalized element. Okay. It's a means of also feeling sometimes of withdrawing from an environmental situation. Okay. Derealization, a feeling that the environment has been changed. That's another derealization. This isn't real. What's happening in this environment isn't real. Hallucinations. Again, this involves a perceiving of a sensory, okay, a perception of a sensory has been changed. You need to understand that this is real to the patient. It is affecting their sensories, okay? So that means auditory, visual, olfactory, taste, and tactile are all, or one, or a couple, it just depends on the patient, are affected. And it is real to the patient. It really is happening to them. Okay? It's not an imagination for them. These things are really happening to the patient. Okay? So when that happens, they're really hearing a voice. They're really tasting something. They're really smelling something. And so when this occurs, it's a real sensory perception that's occurring to them. And so they have to learn how to not respond to that sensory, because sometimes with the medication cannot make it completely go away. So they have to learn how to ignore that. And with that, I left command hallucinations. This is where those voices, that auditory voices, are telling them to do things. That visual is pointing or showing them to do things. And that's where it can become very dangerous, because they may follow the directions, and this is where they harm themselves or can harm someone else. And then, of course, we have illusions. Now, what's an illusion? Those are misperceptions or misinterpretation of a real experience. So picture yourself when you see a shadow in a room, and maybe it's a clothing over a chair, but it all of a sudden looks like a man bent over in your room. An illusion. You misinterpret it. Okay? An illusion, a mirage, any of those type of things that you can think of. An illusion. So alterations in behavior. We've got a load of these, and these are all still considered positive symptoms. Okay, so catatonia. We've got a couple things the way catatonia can go, because sometimes it can be excessive motor activity, okay, where it can be the echolalia with the repeated words, or echoprasia. The echoprasia is where a person is mimicking someone's movement, okay? But most of the time when we talk about catatonia, we're typically talking about somebody freezing in place, okay? They're not moving at all. That's typically when we see them in the hospital setting, is in that kind of a state. And where you see that waxy flexibility, that is where we are able to actually pose the person into a posture. And in order for them to get out of that, we have to move them ourselves. They won't be able to move themselves. The motor retardation, again, is that slowness of moving, versus the motor agitation is where it's very excited movement. So we're running and moving and pacing back and forth, and they will run into traffic. They'll get exhausted. They don't. It can be dangerous because it can knock people down. They just don't stop moving. Stereotypical behavior is just repetitive behaviors that don't serve any logical purposes. And again, that echoprasia is that mimicking movement of others. Okay. Negativism is just a person is just resisting or opposing requests that other people are asking them to do something. Impaired impulse control sounds exactly what it sounds like, is that they just don't have control over their impulses, and they'll walk by somebody's food on the table while they're eating and just grab it and start eating it. They'll eat food off the floor, out of garbage cans. There's increased risk of sexual assaults that can occur, just things that impulse control, that not thinking things through before they go and do it. And it can lead into socially inappropriate things. A lot of times with schizophrenia, there's a lot of social avoidance versus social contact with others, but not always. And then, of course, our boundary impairment issues. Okay, and then also, of course, our gesturing and posturing, having unusual or illogical expressions, also grimacing or positions, just sitting or doing odd things. Okay, and I've already talked about the boundary impairment, drinking and eating other people's food, getting too close into someone's personal space. Those are all those things that we see. Then negative symptoms. The anhedonia, okay, our lack of ability to feel pleasure and joy. This is on page 199. The evolution, the asociality, the affected blunting, which just basically means what, you guys? What do we see? What are we talking about? Their affect. What is affect? Their expression. Okay, reduced or constricted expression. Their asociality. That just is talking about their desire or comfort during social interaction. They just don't have that need. The apathy, the lack of interest in activities. The alogia, the reduction in speech. Okay, or the poverty of speech. So all of this affect, that outward expression of their internal emotional state. Typically we see flat, immobile, or blank facial expression, blunted, reduced, or minimized emotional response. Constricted is another term we use, reduced in range or intensity. So they don't show a lot of sadness or anger or other moods. Inappropriate. A lot of times they're incongruent with an actual emotional state, such as the laugh during an inappropriate response to a tragedy. And then we'll see bizarre behaviors or bizarre affect, where they'll be odd or illogical or inappropriate, or it's unfounded or grimacing. So cognitive symptoms that we'll see, and this is on page 200. We're going to see concrete thinking. And this is where they're unable to do that abstract thinking and not interpret or perceive things and they'll interpret or perceive things in a literal manner and have difficulties discussing things such as love, humor. If that kind of gives you a little bit of a concept of what I'm talking about here. We'll have impaired memory, short-term memory, and the ability to learn things that is a little bit more difficult. Impaired information process, delay in responses, misperception or difficulty understanding others. May lose the ability to screen out insignificant stimuli. Impaired executive function includes difficulties with reasoning, setting priorities, comparing options, placing things in logical order or groups, anticipating, planning, and inhibiting undesirable impulse or actions. Now, does everybody have all these problems? No. But they will have difficulties. Okay, affective symptoms. So what are we doing? We're assessing for depression is crucial, okay? Because it may herald impending relapses because we don't want to take our meds no more. Increased risk of drinking, drugs, increased risk for suicide risk, and it further impairs someone's functioning. Mood may make somebody unstable, make labile changes rapidly and easily, as well as incongruent. So if we're not feeling good, things go. So self-assessment is essential, especially with anosognosia. This is when a patient has the inability to realize they are ill due to their illness. Okay? Inability to realize they are ill due to their illness. This is not denial. They are so sick, they cannot tell that they are ill. Their delusions, their hallucinations make it impossible for them to realize they are sick. Okay, so it's caused by the illness itself. It may cause resistance or they stop treatment. It is also usually combined with them being paranoid, so they won't accept help, and it can become where you have countertransference and feel very frustrated, and they feel like things are impossible to get the patient to get treated. A lot of times the patient will end up on an involuntary status, and it takes a lot of time and building a lot of rapport and trust in order to get a patient to trust enough to take medications to start getting clear. You have to assess yourself. You have to deal with your own anxiety and your own fear, your own frustrations, and your own expectations, so that you can work through and allow the patient to do things on their time, but also know that we're going to do what's in the patient's best interest and help them work forward and with their support systems. Eric becomes anxious and says, "There are worms under my skin eating the hair follicles." How would you classify this assessment finding? A positive symptom, a negative symptom, a cognitive symptom, or a depressive symptom? You should be looking at a positive symptom. Present of something like this, this should not be present. So when we talk about positive symptoms, remember this is something new that did not exist before, where a negative symptom is something where the patient once was able to do, they're no longer able to do. A cognitive is their ability to process information and think and do executive thinking, and depressive symptoms have to do with their mood. Okay, so that kind of helps. So with the positive symptoms, that includes hallucinations, delusions, disorganization, bizarre thoughts, behaviors, and speech. And these symptoms typically appear early. Negative symptoms typically appear later on in the development of the disease process. Cognitive symptoms are usually subtle, and observed impairments of memory also. I forgot to mention that. Okay. So We're going to need to assess for any medical problems, okay, and make sure that there's no medical problems that are mimicking psychosis. We're going to assess for alcohol and drug disorders. We need to do that urine drug screens. We need to do that mental status exam. We need to make sure we have patients' insight into illness. And we need to include cognitive assessment and reality test our patient. We need to assess for hallucinations, delusions, suicide risk, ability to ensure personal safety and health. This also includes assessing for those command hallucinations. We need to assess prescribed medications that the patient may be taking, assess symptomology and impact on functioning, and assess what the family's knowledge level is. It's very important. The psychiatric nurse conducts Eric's assessment, believes that he is also suffering from command hallucination. Discuss what kinds of questions would help confirm or affirm that this is happening. So what kind of questions, you guys, would you be asking your patient? So what would you be asking? Do you recognize the voices? Do you believe the voices are real? Do you follow the commands? What else do you want to be asking? So your potential nursing diagnosis. Positive symptoms, you would be looking at disturbance in sensory perceptions, risk for self-directed or other directed violence, impaired verbal communication. For negative symptoms, social isolation, chronic low self-esteem. There can be a multitude of many more. This is just a few of them. So in phase 1, acute stage, you would be working on patient safety and medical stabilization. In phase 2, the stabilization helped the patient understand their illness and treatment by stabilizing medications and control or cope with symptoms. And in the maintenance phase, stage 3, you maintain achievements, prevent relapse, and achieve independence and satisfactory quality of life. So after the acute admission, discharge is being planned for Eric. What are some of the things that need to be considered that we want to do? So things we have to think about is, where is Eric going to live? What are his economic resources, his insurance, his financial, how is he going to be supported? What's his social support? What's his family relationships going to be like? Is he going to go home and live with mom and dad? Is that going to work? Does he want to go back to school? Is he going to be able to manage going back to school? Or is he going to need to live at home and go to a local community college? How is he tolerating that? What about his internal factors, such as his resilience? What's his coping skills really like? Is he connected with his family? What about his community resources? What about a therapeutic program, social, financial, and others? Is he going to need a guardianship? Is family going to need support group? He going to need a support group. So planning. Got to put the best strategies to ensure his safety and provide symptom stabilization. Make sure the family and the patient are getting educated. And we've got to make sure relapse prevention skills are vital. They got to happen. He's going to have socializing issues. He's got to be reinforced to take his medications. That's probably the biggest thing, is to reinforce meds, meds, meds. So in that acute phase, what do we want to be doing? What interventions are we going to be doing? Medical and neurological evaluations, psychopharmacology treatment, support, psychoeducational and guidance, supervision and limit setting in the milieu. Monitor his fluid intake, right? So we don't have the polydipsia happening. Work with aggression. Regularly assess risk and take safety measures. So again, when we have that patient that's not getting out of bed, not doing their hygiene, not doing the things they need to be doing, we need to get them motivate themselves. This is that therapeutic relationship. We don't want them to do it for us. We want them to do it for themselves. So we're going to point out the obvious. I see you took your shower. How does that make you feel? I see you wearing a different shirt today. How's that make you feel? So that they're motivated by feeling and recognizing they feel better by what they're doing. Attending, if they're having problems interacting with others, having them participate in short duration of activities, then limiting and then keeping it to quiet activities till they're able to tolerate. In the stabilization phase and maintenance phase, we're going to still work on medication administration and adherence, work on the relationships with trust and care providers, community-based therapeutic services, teamwork, safety, and activity groups. Counseling, communication techniques, focusing in on hallucinations, delusions, associative looseness, health teaching and health promotion. So when you're looking in your book, make sure to look over the case studies. Look at the interventions on page 205 with a person experiencing psychosis that continues all the way through 207. Then your nursing care plans on a person with hallucinations, a person with delusions. It gives you just some very good specific things regarding care plans. Again, this is a group of patients. You don't want them doing a lot of caffeine. It's going to interfere with their antipsychotic medications. So these are some of the components that we want to do. So even though in our clinical, we've gone over our movement disorders, I'm just going to reinforce some things. We have our antipsychotic medications. This is our primary drug group that we use with our patients. We have our first generation, second generation, and your blurb does refer to third generation. Typically, that's your Abilify group, but they fall typically under your second generation meds. So with this, they also both come in short-acting and long-acting injectables, okay? So long-acting just means that every 2 to 4 weeks, you're able to administer the medication so that the patient does not have to have oral medication every day. However, no matter what, before you go to a long-acting injectable medication, they have to take the meds orally first due to the fact of the movement disorders, the EPS symptoms, because long-acting, we can't do anything about it, and that can be quite severe. So we need to have the patient take the medication 3 to 5 days orally prior to the injectables to ensure that we are not going to have any acute EPS symptoms. So remember, with the first generation, we are looking at that both of them, they're going to be dopamine antagonist issues. But the first generation targets those positive symptoms. They're not very expensive drugs, and this is why Medicare and Medicaid cover them, okay? But we're going to have severe EPS risk, and there's some anticholinergic effects. Then we're going to have the risk for the tardive dyskinesia is stronger with this group. There's going to be weight gain, sexual dysfunction, and some endocrine disturbances. And of course, second generation affects to the serotonin and the dopamine. And Causeril is one of them that affects that second the serotonin component more, but it treats both positive and negative symptoms. We have less EPS and less tardive dyskinesia issues, but the risk is still there. And the disadvantage is it does cause weight gain, and there's the risk of the metabolic syndromes. Okay, metabolic syndromes. That's the dyslipidemia, the increased glucose, and the increased insulin resistant issues. So again, the pseudo-Parkinsonism is positive for both sides, but it's just less on this side. And we do want to pick second generations over first generations, okay, because it treats both positive and negative symptoms, and it has less movement disorders. Third generations, this is where we've got the Abilify, the Rexulti, and the other one here. They do and attach to both positive and negative, but they're even less risk for EPS and tardive dyskinesia. And Abilify also seems to help a little bit with lessening anxiety issues. Okay, so potentially dangerous response to antipsychotic drugs. Okay, so let's talk about the anticholinergic effects, because these are those life-threatenings again. See, I'm re-hitting it again. And this includes most of the anti-Parkinsonian drugs. Okay, so we're talking about those first-generation ones. Okay, typically the thorazines, the old school ones. Okay, those are the ones that are at greatest risk. Okay, affecting that autonomic nervous system. Okay, and typically instability and delirium is going to set in with that altered mental status, and it's going to worsen the psychosis, especially with our older adults that are going to be at the greatest risk for that syndrome. So just keep that in the back of your mind when we're looking at this from occurring. If you look at table 12.6 on page 216, these are listed out there so that it can just remind you of those potential side effects. I guess it starts on 215, just to remind you of those side effects that can happen and the things you're supposed to do. So of course, when you're having that anticholinergic toxicity response, which you're going to have that urinary retention, the hesitancy, and then the retention will kick in. They're going to be absent bowel sounds because the constipation is going to be occurring. The hyperprexia, the fever is going to be there without any diaphoresis. Their skin's going to be hot. The tachycardia is going to be there. So at this point in time, you're going to hold the med. You're going to call the prescriber. Cooling blankets are going to be getting out. We're going to be sending them out to the ER. Urinary catheterization is needed. The benzodiazepine is going to be on. They're going to sedate. You're going to be dropping using an antipyretic to get the fever coming down. And of course, the patient's going to be becoming more psychotic as the time's going to go on. Something like Artane is going to be going on board, Cogentin is going to be going on board, because they're going to be looking like Parkinsonism is going to be occurring. Their muscles are going to be freezing and they're stiffening taking place during this period of time. So it's going to be looking pretty rough. Then, of course, you have the neuromalignant syndrome taking place. So what is that going to look like? It's rare, it's dangerous, but you got to detect it very early. So their muscles are going to get stiff and rigid. That's probably one of the biggest things, and you're going to think you've got EPS when you don't. And this only occurs at the most 1% of the patients get this. There's going to be, besides the muscles stiffening up, what else are you going to see? A fever. That's the biggest kick. That hyperexia is going to be happening. And we're talking the fever is going to get over 103. There's going to be hypertension with tachycardia. There's going to be incontinence that's going to be taking place, along with delirium. So we've got this fever, you got muscle stiffness. That you see those two things start taking place, you need to move. You need to move very quickly. There's going to be confusion, and you got to get that patient out, because basically if you don't move quick enough, 10% of the cases are fatal. And if you don't move fast enough, that goes up higher. So early detection is your answer, because you're going to onboard fluids very quickly, and you're going to see muscle protein in the blood because of the muscle breakdown and organ failures that are going to start occurring. So you got to move very quickly when this happens. Now, remember which drug causes the agranulocytosis? That's right, the clozapine or the clozaril. Clozapine is the generic name. And with that, you're going to make sure that you're taking blood work and doing the ANC, absolute blood count, otherwise your white blood cell count, on a weekly basis for the first 6 months to ensure that your patient does not have a drop in their neutrophils. And you're doing that patient teaching regarding that sore throat. So that's the big one that you want. Is you got a sore throat, you need to come in right away. That's the risk of that your white blood cell count has dropped. And that's the one we're going to watch. And again, with clozapine, or otherwise known as clozaril, it does not cause movement disorders. So which one causes the QTC wave, the prolonged QTC wave? Which drug? That's typically Seroquel, risperidone, zyprexa, otherwise known as Geodon, your Thorazine and your Haldol and your Mellaril. Those are the ones that typically cause your QT wave to get prolongated. And then almost every single one causes our liver impairment. Jaundice is the thing you're going to be looking for and watching for. And if we've got dark urine, we're in trouble. So hopefully we're noticing the eyes and the skin before our urine starts to get too dark, or our stools getting too tarry, and our bruising being too much. Other medications that we might be needing to pull out are antidepressants if our moods are getting too depressed. And if we're having a lot of aggression and unstable moods, we may see one of our mood stabilizing agents, not lithium, but one of our anticonvulsants being used as a mood stabilizer to assist our patients. Once in a while, we'll also see a benzodiazepine like Ativan get used to help lower down some of the anxiety elements with our patients, the agitation elements. So in advanced practice interventions, Group therapy, psychoeducation, medication and monitoring, as well as prescription, basic health assessment, cognitive remediation, and family therapy. So then we got to evaluate everybody regularly and adjust treatment as needed. Even after symptoms improve outwardly, inside the patient's always recovering. There's always self-esteem issues. We set small goals, you guys, because this is a long recovery process. It takes months. So little steps, little accomplishments. It's active, it's ongoing communication, and caring is essential. When we're doing this, one of the things that's essential is using the ACT team a lot, who go out in the community. I know therapists, I know psychiatrists that will meet patients at McDonald's. Getting the patient sometimes to the doctor's office is very difficult, and they don't drive, because when you have hallucinations, you guys, driving a car can be quite difficult. Getting on a bus can be quite difficult, and having to change buses. So you have to look at what's their transportation. How are they going to get to all these appointments? What's easy, what's hard? And if you're having to battle hallucinations and battle with other people, and other people have expectations and don't understand all the challenges this person may or may not be having, how are they accessing all their care? Well, sometimes it's easier just to meet down at the McDonald's that's a block away from their home. So go out to the community and meet them. So quality improvement. So we incorporate evidence-based treatment. Cognitive behavioral therapy is one of the biggies we use. Create development and incorporate treatment innovations. Examine outcome data and improve patient care and outcome, and adhere to update standards of care and guidelines that incorporate the latest evidence-based practices. We know that long-term injectables result in a long-term outcomes improvements, because oral medication compliance becomes an issue. So loose associations in a person with schizophrenia indicates what? Paranoia, mood instability, depersonalization, poor organized thinking. If you said poor organized thinking, you are correct. Which assessment finding represents a negative symptom of schizophrenia? Apathy, delusions, motor tics, hallucinations. If you said A, apathy, you are correct.